Hello, let's talk about thyroid cancer. Pretty cool SDL. There's three main types of thyroid carcinoma, and they all look totally different, and they've got different blood work as well. There's benign thyroid adenomas, which rarely 1% of the time are going to go toxic and secrete a ton of T4, active thyroid hormone, but most of them are benign. And the big imaging takeaway from this SDL is the radioiodine uptake scan. So thyroid cancers are going to be, they'll present as focal enlargements of the thyroid gland. Think of a nodule. It's like a marble in size, essentially. And this is going to set apart a thyroid neoplasm from a goiter, which is a diffuse enlargement of the thyroid in response to poor iodine intake, causing your pituitary gland to produce a lot of thyroid stimulating hormone. And so you understand that TSH is going to hit the thyroid and tell it to grow and make more follicles in order to produce more thyroid hormone. So very rarely thyroid cancers are malignant. Only about 5% of the time they are. The majority will be benign and thus will show up as these cold iodine uptake scans. Cold meaning that it's not uptaking any iodine from the blood. So that means it's not making thyroid hormone. And then very rarely, again, you get an adenoma, a benign thyroid neoplasm that is going to retain some functionality because it's still well differentiated enough to be able to make thyroid hormone. And in that case, you would see a hot nodule. And again, what's going to separate this from something like Graves' disease, a diffuse hyperthyroidism, is that only part of the gland is really uptaking that iodine heavily. So symptoms of a thyroid cancer, how would it present? Dysphagia, trouble swallowing. The esophagus is right behind the trachea, which is right behind the thyroid. Possibly vocal cord paralysis due to compression of the recurrent laryngeal nerve. And it's going to be a palpable mass, and you might see some swollen cervical lymph nodes as well. Now, the risk of malignancy in thyroid nodules increases as serum TSH increases. Just explain that. TSH causes your thyroid to grow, and if you've got a cancerous cell in your thyroid, the last thing you really want to be throwing at it is a growth factor, and that's what TSH is. Now, you'll catch these nodules, and you'll have to differentiate the swollen thyroid from a goiter. You'll have to say, is this benign, malignant? Is it cystic possibly? And so you'll do a fine needle aspiration biopsy, and that's going to give you your answer once you put that under a microscope. Now, scintigraphy, that's the radio iodine uptake scan. The board's question about this is they'll give you the diagnosis, and then they'll show you 5 pictures of iodine uptake scans, and they'll say which iodine uptake corresponds to this patient's diagnosis. And so in the case of cancers, I want you to understand 99% of the time, the thyroid nodule is going to be cold, which means it's not going to take up any iodine. And so think about a cancer. We've got a spectrum from well-differentiated to de-differentiated. And well-differentiated means that that neoplasm is retaining some functionality of the tissue it's been derived from. But de-differentiated means that all bets are off and that that cancer does not care about maintaining any sort of normal functionality. It's just growing and dividing as rapidly as it can, and that's all that it's trying to do. So look at this papillary thyroid carcinoma on the left side of this image. And do you see any thyroid follicles? Do you see any colloid in those follicles? I don't. Colloid should be pink, you know? And what I'm seeing instead is a large degree of fibrosis with some lymphocytic infiltration and these follicular cells that just look ragged, yo. They look worn, they're beat. And so do you think that this thyroid gland is going to be pushing out very much T4 from these cells that look so worn? I don't think so. So that's why you get a cold nodule. This cancer doesn't care about making T4. And so the bad part of that is that what's the pituitary's response to this cancer that's not making any thyroid hormone? Well, it just throws some TSH at it. And that's just going to propagate the problem. It's going to make it so much worse because, again, thyroid stimulating hormone, these cells are all expressing TSH receptor because they're thyroid cells. How could they not? And so that's going to make the cancer go downhill very fast. So here is an example of some iodine uptake scans. You got a normal thyroid here. You've got Graves' disease, which is diffuse hyperthyroidism. And then you've got a toxic adenoma, which is going to be 1% or so of all thyroid adenomas. Again, this is very rare, but toxic means that this part of the thyroid is making T4 independently of needing any TSH at all. It's just grossly overproducing it. And it's usually due to gain of functions in the thyroid stimulating hormone receptor. And over here is a toxic multinodular goiter. And so obviously that differential is because there's many different foci of iodine uptake lighting up on that. And we're going to call that hot nodules, you know. And so this toxic adenoma, that's a hot nodule singular. So that's how they ask the question. Here's what a cold nodule looks like. Cold means it's not taking up any iodine because we just said, look at this picture. Do you think this thyroid wants to make any T4? No, these cells don't care about that. They're cancerous. So you get the cold nodule, and cold equals cancer in the thyroid because it's just about the only thing that would give you a cold nodule. And most cancers are going to be non-functional and thus cold. So that's how they want to ask that. And in the SDL, confirming everything we just talked about, 85% of nodules are cold, most benign, and virtually all malignant thyroid nodules concentrate both radioisotopes less avidly than adjacent normal thyroid tissue, so that means they're cold. About 5 to 8% of cold and warm nodules are malignant. Warm means normal, hot means like jet black, and then about 5% of nodules are hot, very rare, definitely the minority. Malignancy is virtually non-existent in hot nodules. And that's because those malignant cells are more dedifferentiated. So how do we diagnose these? Fine needle aspiration. You're almost always going to get one of these on a thyroid nodule. I don't see any reason why not to. It's safe. It's minimally invasive. It's got a high sensitivity, false negative rate, and it's got a high specificity. It means low false positive rate. So the different thyroid tumors, we're really focusing on the papillary and follicular carcinomas, as well as the medullary carcinoma. Thyroid nodules tend to present in the 4th, 5th, and later decades of life. A little bit of a female gender predilection. Risk factors for thyroid neoplasms include radiation. That's a big one. And we used to radiate people cervically and on their head if they had tinea capitis, which is scalp ringworm. Remember, that's a dermatophyte, and we treat that with things like griseofulvin, microtubule inhibitor, and terbinafine, squalene epoxidase inhibitor. So patient would present with a big bald patch, you know, kind of in the middle of their head, or maybe that big ringworm type rash on their neck. And then we would just throw some radiation at it. And it turns out that's not the best idea at all, because that really damages your cells and can predispose you to cancer of the head and neck. And so what's in your head and neck? Well, a lot of lymph nodes and white blood cells, but also your thyroid. And so thyroid cancer is downstream from radiation. Another risk factor of thyroid cancer is going to be low iodine intake, which is going to predispose you to a goiter. And so when you have low iodine intake, what that means is that you're not making a lot of T4. And so your pituitary throws TSH at your thyroid to try and get some T4 out of it. And so that's the mechanism behind the enlarged goiter. That's your diffusely enlarged thyroid gland. It goes hyperplastic, and those cells divide and divide and divide because you're just trying to get more T4 out of the thyroid. So that TSH makes cells divide, and with increased cell division comes an increased risk of cancer. Histologic subtypes. Understand that most thyroid carcinomas arise from the normal follicular cell, which is this cuboidal little thing that kind of looks like renal epithelial cell, renal tubular cell. It's got a basolateral and an apical side, and the apical side is the side facing the colloid-containing lumen. And then you've got these medullary thyroid carcinomas, which are very distinct in their presentation, that arise from calcitonin-producing C cells. And calcitonin is a hormone that drives calcium into cells from your bloodstream to lower blood calcium. Let's talk about the follicular adenoma. This is a benign neoplasm. We know it's an adenoma, not a carcinoma. And so because it's benign, what does that mean? Well, that means it's non-invasive. And we know that it's non-invasive because when you cut one of these suckers out, they got a nice clean envelope around them. They're contained in a capsule, in a box, in a package. And if you look at it under the microscope, you can see that fibrous capsule clearly demarcating the boundary of the tumor from the surrounding soft tissue. So that's the big differential from a follicular carcinoma. Now, these adenomas are typically cold, but a very small percentage of them are going to be hot. And hot, remember, means that it's taking up a lot of iodine whenever you give a patient radio-labeled iodine. And so we would call that toxic. And toxic is referring to the fact that it's just making T4 like there is no tomorrow without being told to make T4 by thyroid-stimulating hormone. So that's a minority and that's an exception, but just in case you see the hot nodule, you understand that that means that that part of the thyroid is making T4 independent of needing TSH. And how could it do that? Well, typically gain of function mutations in the thyroid stimulating hormone receptor gene or the G protein alpha subunit of that receptor. Gain of function mutations in those proteins are going to lead you to where one molecule of TSH is going to just activate a thyroid cell for a long, long time rather than just transiently activating it. And so that's part of what uncouples a toxic nodule from the need for thyroid stimulating hormone, and we call that autonomy. And just remember that benign tumors have a great capsule around them, and that's really all you need to know about them. So now we get into malignant tumors of the thyroid. And first, we're going to start with the papillary thyroid carcinoma. You need to remember that these are going to have gain of function mutations in the BRAF and RET oncogenes. And the RET oncogene, there's a little bit of an overlap with the medullary thyroid carcinoma, but they look totally different on histology, and they also have different staining properties and lab findings. So a summary of the papillary thyroid carcinoma: they're going to be cold nodules. They are not going to be hot. They are not going to be making excess T4. They're not going to care about making T4 because they're a cancer, and properly serving their normal physiological function is the last thing in the world that is on their mind. They're going to show Psamomma bodies, which are spheres of calcifications. They look very similar to keratin pearls, but that's a very, very common gimme in test questions to help you make the diagnosis, or they might even ask you, what do you expect to see in this cancer? And you'd say Psamomma bodies, calcifications. The most common cause of papillary thyroid carcinoma is a history of radiation. And histologically, you see these cells with clear eye nuclei. They're called orphan Annie nuclei. I don't know why. That's one of the last things you would get asked about, but it is something that might help you make the differential. And finally, this cancer likes to metastasize locally to cervical lymph nodes. It does not like to metastasize hematogenously to the blood, to bones, to the lungs, etc. That's going to be our follicular carcinoma. So papillary, what does that mean? It means it kind of looks like a sea anemone, you know, and we've seen papillary cancers in the oropharynx and the larynx. We've seen them associated with human papillomavirus. And so you understand that a papillary cancer, if you were to slice it in this plane and then twist it 90 degrees in a couple of axes, you would see basically a bunch of fingers looking back at you. And that's kind of indicative of the stalk-like nature of the architecture of this protein. It's got fibrous stalks, and then it's got cells lining those fibrous stalks, kind of similarly to how a villus look, or a villi, how villi look in the small intestine, you dig? Or crypts in the colon, maybe, you know? So you've got this finger, and then you've got cells lining it, and that's a papillary architecture. That's absolutely characteristic of the papillary carcinoma. We've seen papillary carcinomas in the kidney too, and those also did display Psamomma bodies. So anytime you see the word papillary in the cancer, think Psamomma bodies. That fibrovascular stalk, if you understand what you're looking at, what slice of the tissue you're looking at, you know, this would be kind of like an axial slice right here on the lower left, and here's your fibrovascular core in the middle, And then if you were to slice it more longitudinally, there's your fibrovascular core right there. Again, very typical of the papillary carcinoma. No other thyroid cancer shows you these fibrous cores quite like that. Here is a Psamomma body. It's a bunch of calcium in concentrically layered rings, so like rings on a tree. Here's a fine needle aspiration, and that's a quite interesting way to get you to make the diagnosis. These big clear nuclei would hopefully be part of the presentation on a fine needle aspiration if they were to throw it at you that way. What do they want to ask you about the papillary carcinoma besides the Psamomma bodies? Probably the genes. They would want you to understand that there are mutations in the BRAF gene and in the RET oncogene. That's a big question. And I've highlighted those in purple on this chart. And then the ones that correspond to the follicular adenomas, I've highlighted in orange. But all of the mutations in thyroid cancers are relatively related in that they're from the same pathway. So take a good look at this once, take a good look at it the morning of the exam, you'll be good. These patients with papillary carcinomas don't typically present with hyper or hypothyroidism, so T4 levels are relatively consistent because the pituitary can compensate for any low T4 just by spiking up TSH, so that might be elevated. And then again, you're going to see cold nodules on iodine uptake. These have a very good prognosis, and they only metastasize regionally, really. It does say distant hematogenous, but how that question gets asked is in comparison to the follicular carcinoma, which almost always goes hematogenously. So let's talk about the follicular carcinoma. We looked at the follicular adenoma, and the main cancerous cell for this follicular carcinoma, as well as the papillary carcinoma, is going to be the follicular cell of the thyroid. Just these little dudes here lining follicles, and follicles are those lumen which contain colloid. So what's going to set this apart from your papillary carcinoma is that the follicular carcinoma contains no papillary elements. So none of those fibrovascular stalks, none of those fingers or frond-like appearances. It looks relatively like a normal thyroid. You want to understand the genes involved with this one as well, the RAS oncogene, the PTEN tumor suppressor gene, and then there's a 2 to 3 chromosomal translocation involving PAX8 PPAR. You won't have to diagnose these things based on how they look visually, I don't think. You want to understand the histology, and you want to understand that what sets the carcinoma apart from the adenoma is going to be invasion of the tumor through this fibrous capsule into surrounding tissue. That means it's malignant, which is why we would call it a carcinoma. A section talking about the phosphoinositol tris kinase pathway, which is covered on that page a few pages back. RAS oncogene, follicular carcinoma. So what else could they ask you? Where's the most likely metastasis? And again, if it's papillary, you're thinking cervical lymph nodes, but if it's follicular, you're thinking bones, you're thinking skull, you're thinking lungs. So then we have the anaplastic carcinoma of the thyroid. Easy diagnosis. I mean, it just goes downhill like a snowball. And you look at it under a microscope and it is all messed up. It doesn't know what it's doing. You see dramatically enlarged and swollen cells with extremely hyperchromatic nuclei caught in the middle of the act of mitosis. These patients typically have, well, not typically, but a quarter of these patients do have a past history of a thyroid carcinoma. So that's a big predisposing factor there. You will see a large degree of necrosis and of hemorrhage, hence the name anaplastic, which is the term that we give to just about the worst tumor of any given tissue. So the net gets really big really quickly. Compressive symptoms are more common in this tumor than they are in the more slowly growing thyroid tumors. Once more emphasizing that you see cold nodules on radioactive iodine uptake, because look at these cells in the top right. Yo, do you think that they are concerned whatsoever with making T4? I don't think so. I don't think you are going to get much thyroid hormone out of those cells at all. Now let's discuss the medullary carcinoma. Characteristic to the medullary carcinoma is the presence of amyloid on histological section, and it will also stain positive for calcitonin because the tumor arises from C cells, which normally do secrete calcitonin into the bloodstream. And so calcitonin, I remember that puts calcium into cells. The N at the end of the word reminds you that it pushes calcium from the bloodstream into cells. And so then if you remember that calcitonin is directly antagonistic to parathyroid hormone, well, then you'll never forget what either of them do, because if you remember calcitonin puts calcium into cells, you'll remember that parathyroid hormone pulls calcium out of cells and puts it in the bloodstream. So the RET oncogene is not only associated with the papillary carcinoma, it's also associated with the medullary carcinoma. But that's okay, because the papillary carcinoma will show you Psamomma bodies with calcifications, and the medullary carcinoma will show you amyloid staining with calcitonin positivity. And it will probably also be associated with multiple endocrine neoplasia 2A or 2B. Now, First Aid has a really good page on multiple endocrine neoplasia. Remember your 3 Ps, 2 Ps, and 1 P for those. And then remember that medullary carcinoma sits right in the middle of 2A and 2B. Amyloid in up to 80% of cases. What's that mean? That means that if they want to ask you about this on the test, it's going to stain for amyloid. Why would it not? And because amyloid also stains positively with calcitonin immunostains, that's a different way they can phrase it. So once more, the cell of origin is the C cell, not the follicular cell. And then we discussed the RET proto-oncogene, which is most useful not for diagnosing this cancer, because the amyloid stain is obviously very specific for this particular thyroid cancer. The RET proto-oncogene is useful for screening family members to see if they are predisposed to developing the same medullary thyroid carcinoma as their affected relative. So 97% of patients with multiple endocrine neoplasia 2A and 95% with MEN 2B do have activating germline mutations in the RET oncogene. And the RET oncogene also represents a therapeutic target for medullary carcinomas. Specifically, sunitinib is the monoclonal antibody that we've got to try to dampen the responsivity of that RET tyrosine kinase receptor to growth factors. So here it is in the text: genetic screening with sensitive polymerase chain reaction for germline RET mutations. And germline means you inherited it. It's not sporadic, it's not something that happened after that, it's something that was there when that happened. So you perform that in at-risk patients who, again, are going to be close relatives of whoever gets initially diagnosed with medullary thyroid carcinoma. How do these present? Same story. Asymptomatic thyroid nodule. Again, it's not diffuse. It's clearly on one side or the other, or maybe it's on up or down, but it's not the whole thing. And might cause dysphagia, might cause dysphonia. High plasma calcitonin in this case corresponds with flushing and diarrhea, because calcium is under a calcitonin signal leaving the bloodstream going into cells. And so when calcium goes into your enterocytes, it's just going to diffuse out of them through some antiports or symporters, and then you're going to get a lot of calcium in the lumen of your gut, and that's going to have some sort of a stimulatory effect on your GI tract. Elevated basal serum calcitonin levels are diagnostic of medullary carcinoma. So what that means is, understand this is the only thyroid cancer you're going to see calcitonin up in, and they're going to give it to you, So medullary has the worst prognosis of all of these thyroid carcinomas except for anaplastic, but you recognize the word anaplastic, and you know that anaplastic means this is really bad right now. So of course anaplastic is the worst, but then of the three normal-ish variants, papillary, follicular, medullary, Medullary is going to be the worst prognosis. Papillary is going to be the best. So the order that they're in this SDL is the order of the prognosis from best to worst. And that's about it. As far as cancer SDLs go, this is lenient. So let's look back over. Again, there's the genes, but I mean, you only got to rep those a couple times, just flashcard them a couple times and you got them. We've got RAS for the follicular thyroid carcinoma. We've got RET for the other two. We've got P10 for the follicular thyroid carcinoma, and that's a tumor suppressor gene, but all the rest of these are going to be oncogenes. And then we've got not only RET, but BRAF for this papillary carcinoma. The papillary carcinoma, again, we're thinking fingers, we're thinking fronds, we're thinking sea anemone. We look at it under a microscope. That's exactly what it looks like. If they want to give you a fine needle aspiration, that is cruel and unusual punishment. That's that second-year resident type stuff. So honestly, if you see that on a test, just laugh because everybody else is going to get it wrong. Remember Psamomma Bodies for the papillary thyroid carcinoma. I would like to bring up great mnemonic from first aid. Get my big old head out of the way. Psamomma Bodies. All right, there's a P, there's an S, and there's two M's. And so there's 4 different families of tumors that are going to show Psamomma calcifications. And so they're not going to tell you Psamomma bodies, duh. They're going to say concentrically laminated calcification or spheres of calcification. And so if it's one of these 4 tumors that you're diagnosing, the answer is, what else do you see? Calcifications. So papillary carcinoma of the thyroid, and we have also seen a papillary carcinoma in the kidney that will also give you Psamomma bodies. So you see the word papillary, you're thinking Psamomma bodies. The serous papillary cystadenocarcinoma of the ovary, we'll get there too. Meningiomas, remember, what are your meninges? We're thinking like dura, pia, arachnoid mater up in the brain that's providing a casing around your brain. And malignant mesothelioma, where do you get that? The lungs, that's a cancer of serous connective tissue. And that's Psamomma bodies. That's about all I got for this SDL. Scrolling back up, the benign adenoma. Notice how similar the thyroid looks to the kidneys. I think this is just fascinating, Like, I mean, honestly, you might as well be looking at just a bunch of collecting ducts right here, or a bunch of convoluted tubules, So if renal phys was your thing, then understanding how the thyroid produces thyroid hormone and where the thyroid hormone goes next and the histology of the thyroid, that's going to be no big deal at all to you. Benign, encapsulated, malignant, breaking out of its capsule. And again, the question for the iodine uptake scan is, they show you the picture and then they say, what's the diagnosis? Or they give you the diagnosis and they show you 5 pictures and then you choose the uptake scan that corresponds to the diagnosis. So just be thinking, they'll also give you blood T4 and blood TSH, right? And so that's how you diagnose the thyroid, So which way is TSH going? Well, which way is T4 going? So if T4 is up and TSH is low, you suspect there's some sort of toxic thyroid pathology going on, maybe a toxic multinodular goiter, maybe a toxic benign adenoma, maybe just pure hyperthyroidism like Graves' disease. And so then you make your differential based on clinical symptoms. But if T4 is down and TSH is up, then you would probably be expecting to see something like a cold nodule wherein the thyroid has lost some functionality. That's all we got.